Now we come to the diagnosis of abdominal tuberculosis. When we come to diagnosis, before we move into investigations, we should first know the Paustian's criteria. There is a old criteria given by Paustian. This Paustian's criteria is no longer found in books like OP Gai or IAB textbook, but it still has a potential of being asked in your entrance exam. So the name first is important. It is called as Paustian's criteria for abdominal tuberculosis. So what is the criteria? There are 4 criteria which are mentioned. Any one out of these 4, if it is present, you should suspect abdominal tuberculosis according to this criteria. So first of all, when you do animal inoculation or culture of material taken from either intestine or mesentery or lymph node sample, that should grow tubercle bacillus, right? Second, when you do histology of the lesion, you should find acid-fast bacilli belonging to Mycobacterium tuberculosis. Third, when you do histology, even if no acid-fast bacilli are found, there should be caseous necrosis with inflammation. And fourth, when you do a surgery or when you do autopsy, then retrospectively you should find intraoperative findings of matted intestinal bowel loops along with biopsy of mesenteric lymph nodes consistent with tuberculosis. So these are the 4 criteria. Any one is present, it is diagnostic of abdominal tuberculosis. However, these days we don't give too much importance to this criteria because many patients can have abdominal tuberculosis despite not fulfilling any of these criteria. But for entrance exam, you should remember at least the name. So what are the non-specific investigations? First of all, we have anemia. When you do hemoglobin, a moderate to severe degree of anemia is seen. On examination, it will manifest as pallor. The type of anemia, although it is not specified, but generally it is seen that it is either normocytic normochromic or more commonly it is microcytic hypochromic, which is due to anemia of chronic inflammation. So anemia is the first non-specific investigation which can, add up to the workup. Secondly, you can find raised ESR in many of these individuals. However, elevation in ESR is non-specific. It can occur in non-tuberculous conditions also. And even if in abdominal TB you find raised ESR, degree of elevation in ESR does not correlate with clinical severity. It's an old MCQ point, so you can write degree of elevation of ESR does not correlate with clinical severity. Old statement based MCQ. Then we have hypoalbuminemia, decreased serum albumin levels. Usually the serum albumin levels are below 2.5 grams per deciliter. You will find leukocytosis in around 50% cases. However, typical lymphocytosis may or may not be seen. And finally, MAN2 test, when you do it, positivity is seen in only about 50% of these individuals. When we go in for plain X-ray abdomen, when we start investigating, when you do X-ray abdomen, you can find presence of enteroliths. So they are calcified material which are present in the intestine, which is seen in chronic tuberculosis, can occur in any form. Secondly, you can find calcified lymph nodes or calcified granulomas in the patient. And thirdly, you can find dilated bowel loops with multiple air fluid levels. So air fluid levels similar to subacute intestinal obstruction, that kind of presentation can be seen. It's not necessary that all of them should be present. Any one of them can be seen, and one patient will not have all of these manifestations. Any one of these manifestations may be seen. So this is a photograph which is showing multiple air fluid levels in a patient with tuberculosis. A very, very important point. Please remember that in any suspected abdominal tuberculosis, whether it is in child or adult, you should always do a chest X-ray as well. Why are we doing a chest X-ray? To identify any primary focus which is present. It is not always present, it is not always identifiable, but if you are able to identify it, it will add to our diagnostic accuracy. Then we will do barium studies. Barium studies can be done in the form of barium meal follow through, which is useful for small intestinal lesions, and you can do barium enema, which is useful for the large intestinal lesions and the ileocecal region. So barium studies, what are the findings that you will find? There is a lot of signs which are mentioned in textbooks. All of them are potential MCQs for your entrance exam. So first of all, when you do barium meal, you can find that there is a hypersegmented barium column. It is also called as chicken intestine, right? Second, there may be nodular thickening of the mucosal folds in the small intestine. Third, you can find a hourglass stenosis or a napkin ring constriction in the patients. And fourth, you can find a sign called as Fleischner sign, which is a potential MCQ, also called as inverted umbrella sign. So there will be thickening and wide gaping of the ileocecal wall with a narrow terminal ileum. So a Fleischner sign is shown something like this. So it is looking like there is a large umbrella which has opened up and inverted. You know, when there is a storm and you are walking with an umbrella, it gets inverted inside out, and you are trying to hold it against the storm. So there is the wide gaping ileocecal wall which is present here, and this is the dilated cecum which you will find, and there will be a narrowed terminal ileum going like this. So this type of an appearance is called as inverted umbrella sign. So it looks like an inverted umbrella, so we call it as inverted umbrella sign. So if you find a photograph, it's a very classic photograph. There are very little photographs. If you look at, most of the review articles, you try to do Google images, you try to look at the standard books, this image will keep recurring there. So please remember this image. This is a very classic image. These signs require a lot of expertise and a lot of visual memory to be remembered for your exam. So it is a potential visual Fleischner sign seen in abdominal tuberculosis. There are more signs. There is a sign called as string sign of Cantor. There will be persistent narrowing of the colon due to stenosis. So string sign of Cantor will look something like this. This is not string sign in the upper part of colon, as you can see. This is the string sign. Can you see this white arrow which is pointing here? So string sign, when we say, when you pull a thread and the thread is, this is a thick thread, and the thread is soon going to, break. Before that, there might be a very thin thread joining the two. So this is a thick thread, this is a thick thread, you are pulling it in opposite direction. So there is a small thread which is in between holding the two, and soon it snaps and the two parts separate. This is the part which is called as, the intestine appears like this, so we call it as string sign of Cantor. There will be localized extended area of constriction or stenosis in abdominal tuberculosis. We call it as string sign of Cantor. As you can see in this picture, there is a very long, starting from here till here, you can have a narrowed area. This is called as the string sign of Cantor. Next we have conical cecum. Conical cecum which is shrunk and pulled out of the iliac fossa due to contraction and fibrosis of the mesocolon is called as conical cecum. Next we have gooseneck deformity, where there is loss of ileocecal angle and there is a dilated terminal ileum appearing suspended from a retracted fibrosed cecum. Gooseneck deformity, all of these lesions cannot be present together for obvious reason. So how will you find gooseneck deformity? This is a photograph which is showing you a gooseneck deformity. If you try to see here, you will find that there is a dilated terminal ileum, this one. In the previous one, we had a narrow ileum. Here there is a dilated terminal ileum and there is a loss of ileocecal angle. So it is looking like as if a goose is sitting. I'm bad in making diagrams, but this is how the gooseneck deformity is looking like in this. Since the shape is looking like that of a goose, so it is called as gooseneck deformity. And finally, we have Sterling sign, where there is narrowing of the terminal ileum with rapid emptying into a shortened rigid cecum. So these are some of the named signs that you must remember. At least the names are important. If you can't, identify, nobody is going to, if they give you a photograph in the exam, be assured that it will such be classic picture that if you have read at least once, you will be able to identify it. Eyes see what the mind knows. If you know the description, if you know the names, you can easily identify and reach the correct answer. And remember that both Sterling sign and string sign of Cantor, they are non-specific. They can also be seen in other conditions, especially Crohn's disease. So they are not exclusive for abdominal tuberculosis. They can be seen in Crohn's disease as well. Next is ascitic fluid examination. Ascitic fluid examination findings are very important for your super specialty exam. Please remember these. They can be asked as a standalone question. They have already been asked if you look at older papers. So what do you find when you do a check for ascites in abdominal tuberculosis? First is the appearance. It will be a straw colored fluid. Second, it is a low SAG. SAG stands for serum ascitic albumin gradient. So it is a type of exudative fluid with the serum ascitic albumin gradient less than 1.1. Then the protein content will be on the higher side. There will be more than 3 gram% of proteins. The cell count is variable. It varies between 150 to 4000 cells per millimeter cube, and 70% of them are lymphocytes. Acid-fast bacilli are not that frequently present. The positivity, if you do a smear, is seen in only 3% cases. However, culture will be positive in approximately 20%, but culture will take about 6 to 8 weeks. So, for all practical purposes, we do send for culture, but we don't need to wait for the report to come. You need to understand that most of these tubercular infections in children, including abdominal TB, they are paucibacillary infections, and so we have to rely upon the clinical presentation, degree of suspicion, plus any clue in these investigations. If it is present, we need to start management on those lines. Then a very important thing that we do in these patients is adenosine deaminase levels. Adenosine deaminase levels are found to be high, although they are not specific, but as a part of group of investigation, it definitely improves the accuracy, and the cutoff used is more than 33 units per liter across post-infancy age groups. Then finally, interferon levels, including interferon gamma levels, if you do them, they will found to be high, but they are not easily available at all places. So this is the ascitic fluid findings we find in patients with peritoneal TB, the wet variety. Then we do a test called as IGRA or quantiferon assay. IGRA stands for interferon gamma release assay. Interferon gamma release assay or quantiferon assay is also called as quantiferon TB gold test. It is an in vitro blood test which is used to detect cell-mediated immune response to tubercular bacilli. It is specific for tubercular bacilli, and so you can easily rule out the other non-tubercular infections. And it is a highly sensitive and specific test, but the problem is it cannot distinguish between active and latent tuberculosis. So, IGRA test has now been validated for use in children as a supportive investigation. Now, what does Nelson say? Nelson 21st edition says that there are two clear advantages of IGRA when you do for tuberculosis, including abdominal tuberculosis. First is you require only one visit, so there is only one patient encounter. Remember that in MAN2 test, like your typical TST test, first you will give MAN2, then 40 to 72 hours later you will again check the patient for the induration erythema which is coming. So these patients, IGRA will be a single encounter, single visit test. Second important is there is lack of cross reaction with either BCG or other mycobacteria, so there is an increased test specificity for tubercular infection. So this is important that Mycobacterium tuberculosis infection is shown and vaccination related phenomena can be ruled out. Then what are the newer tests which are available? There is a test called as ELISpot which checks for T cells specifically directed against Mycobacterium tuberculosis. We have NAT which stands for nucleic acid amplification test. It mainly includes your PCR for tuberculosis, and it includes Gene Expert MTB /RIF. It is a real-time PCR that detects rifampicin resistance in MDR-TB, and it gives within 2 hours it gives a report of the presence or absence of tubercular infections in the patient. It is expensive. It comes in the form of cartridges which are very costly, but wherever facilities are available, Gene Expert can be again a useful diagnostic. All of them are, they are considered to be supportive tests. In the absence of clinical feature or clinical suspicion, by themselves they are not diagnostic of the disease in the patient. Then the traditional investigations, we have already talked about X-ray. What do we find on ultrasonography? Ultrasonography will first of all show you the presence of free fluid in the patient, so ascites will be seen in these patients. Secondly, you will find a sign called as club sandwich sign, also called as inverted bread sign. So these named signs are important. There will be fluid between the radially oriented bowel loops. Third is the pseudo-kidney sign. Pseudo-kidney sign is basically the ileocecal region. The ileocecum gets pulled upwards and it comes to lie in the subhepatic region, and that it sometimes can be confused with a kidney being present. So that is called as a pseudo kidney sign. It is pulled up to a subhepatic position. Then mesenteric lymph nodes, para-aortic lymph nodes and paracaval lymph nodes, they may be enlarged and they may be calcified. The lymph nodes will show mixed heterogeneous ecotexture, and if you find that there are anechoic or hypoechoic areas in the lymph nodes, they are highly suggestive of caseous necrosis. Remember that anechoic areas suggestive of caseous necrosis will never be present in a patient with lymphoma having enlarged lymph nodes. So if somebody asks you on ultrasound, how will you distinguish that the lymph nodes are enlarged due to tuberculosis or due to lymphoma? Look for anechoic areas within the lymph nodes. If there are anechoic areas present or severely hypoechoic areas are present, that indicates presence of caseous necrosis. Central caseous necrosis is not found in patients of lymphoma. Eventually, obviously, you need to do biopsy and look at the overall picture, but this is a very useful clue for your exams, that lymphomatous enlargement of lymph node versus tubercular enlargement of lymph node, how you differentiate on ultrasonography. Look for anechoic areas. Next is your CT scan, CT abdomen. We start with plain CT, we take a few images and then contrast CT is performed. It can detect bowel wall thickening, it can tell you adherent loops, it can tell you ulceration and nodularity in the bowel. Enlarged caseating lymph nodes can be visualized and they will show hypodense centers due to caseous necrosis and peripheral ring enhancement. Due to, see, in the center there will be caseous necrosis, so there will be hypodense, decreased density center. Around that there will be inflammation composed of your epithelioid granulomas, mononuclear inflammatory infiltrate, and you will also find Langerhans Z cells if you do biopsy. So all these inflammatory lesions will increase the contrast uptake, increase the vascularity around that hypodense area, producing peripheral ring enhancement when you perform a contrast CT. So central hypodense with peripheral ring enhancement indicates abdominal tuberculosis. Then calcification of lymph nodes can be seen. We know that CT is good for detecting calcification. Retroperitoneal lymph node involvement as an isolated finding is very, very rare. So only retroperitoneal lymph node involved, no other lymph nodes getting affected, it is not likely to be abdominal tuberculosis. CT can also detect complications like perforation. And finally, mesenteric involvement can give a star-like appearance, also called as stellate appearance. Then we can do a GI endoscopy. GI endoscopy is useful for upper GI lesions. As we shall see later, that esophagus and stomach are very seldom involved. So in the proximal involvement, duodenum involvement, jejunal involvement, GI endoscopy can be used. So there are modifications called as enteroscopy and wireless capsule endoscopy, which are being used in adults, and they are also being tried in children these days. For lower GI involvement, colonoscopy can be done. For colonic and terminal ileal tuberculosis, they will show mucosal ulcers and nodules, and biopsies can be taken from the edge of the ulcer. So biopsy can be taken from the edge of the ulcer. If you do biopsy, what all findings will you find? So biopsy will show caseous necrosis. It may or may not be present, but the usual findings in abdominal tuberculosis will be caseous necrosis. There will be granulomatous inflammation composed of macrophages, epithelioid granulomas, and Langerhans type giant cells. Then ultrasound or CT guided FNAC of the abdominal mass can be performed. Then liver biopsy can be done for suspected liver tubercles, and laparoscopy, if you do, laparoscopy is useful to detect peritoneal TB. Two patterns can be seen. Either there will be thickened peritoneum with or without tubercles, and secondly, there will be fibroadhesive peritonitis. There will be fibrosis, there will be adhesions in producing a low-grade inflammation in the peritoneal lining. And finally, laparotomy. Laparotomy is needed only in exceptional or diagnostic dilemma cases where you still cannot reach the diagnosis despite all the investigations done.